Okay, are there any questions? If there's no questions, let's go ahead and get started. So we were talking about hypersensitivities, and we mentioned that the immune system can defend someone, but it can also make you sick. And one of the ways it can make you sick is when your immune system responds and causes a hypersensitivity. The first one, type 1, hypersensitivity type 1, is also called the anaphylactic response. And that is when your immune system acts quickly to respond to something that you're really allergic to. And the best examples of this are when you're allergic to a bee sting, for those people who are allergic, or I mentioned I was allergic to the bite of the fire ant, and many people are allergic to hay fever. The first time you are exposed to this, you just become sensitized, and your body produces IgE, which then coat mast cells and basophils, and then the patient is primed. And probably on the first year, that's all that happens in the first year. But then every other time you're exposed to it, you then can have a hypersensitivity, which if it's localized, it's just an allergy, and it's not usually, well, it's not a life-threatening problem, it's just an annoyance. But if it's systemic, it can be life-threatening. And then hypersensitivity type 2, the cytotoxic hypersensitivity response, is when the patient makes antibodies to something that it'd be better if they didn't make the antibodies to it. And that's true of all the hypersensitivities. But we mentioned that the Rh incompatibility was an example of type 2 cytotoxic hypersensitivity, where when a baby is Rh positive and the mother is Rh negative, if the baby's blood mixes with the mother, then the mother will make antibodies against the Rh positive blood. Now, usually for the first baby, that's not a problem because this baby will be born before the mother's antibodies get formed, or before the antibodies get formed and then have enough time to attack the first Rh positive baby. It's in subsequent pregnancies with Rh positive children that this can be a problem, and the mother's anti-Rh antibodies then attack the fetus's Rh plus blood, and that can be very serious for the fetus, and it can kill the fetus. So that's how severe it can be. And that actually was the number one problem in childbirth before the advent of modern medicine, meaning the Rh incompatibility was the problem in pregnancy. Now, of course, there's modern medicine that stops that from happening. And then we're now going to talk about type 3 immune complex hypersensitivity. And this happens when a small antibody, such as IgG or IgA, binds to a small antigen. When this happens, the small antigen and antibody bound to it is small enough that it continues to circulate in the patient, meaning it's not a big enough complex when a small antibody like IgG or IgA binds to a small antigen. If it's a large complex, it'll precipitate out of the blood, and then the kidneys will remove it. But if it's a small antibody-antigen complex, it can move around in circulation and then cause problems for the patient. And this almost never happens with the antibody IgM because it's a very large antibody. And usually when IgM binds to an antigen, that complex would be large enough to precipitate from the blood. But if it happens with a small antibody like IgG or IgA, then this complex can circulate in the body, and it can get stuck in small places such as capillaries and joints. And then when they are bound to their complex, I guess that would be the example here, they can call down inflammatory chemicals like the complement proteins can bind to the antibody that's bound to an antigen, and the inflammation can happen. You don't want inflammation in your joints or in your capillaries because they're small and they are capable of being damaged. And each time this happens, there will be more damage that'll happen in the capillaries or in the joints. Some examples of type 3 hypersensitivity are when IgA binds to antigens and causes pneumonitis. And it can usually be dust or mold that's breathed into the lungs. And it's often called farmer's lungs, or pigeon breeder's lungs, or librarian's lungs. These individuals have an immune reaction when they breathe something from their occupation, like the farmer, they breathe the mold, usually on hay or something like that, and then it gets into their lungs. Or the librarian, they breathe in the dust that collects on books, and they get librarian's lungs. I actually know a farmer who has this reaction, farmer's lungs, and whenever he handles moldy hay, he will have pneumonitis, meaning an allergic reaction in his lungs, and he has to be hospitalized when it happens. And he says it's really awful. It feels like my lungs are totally congested and I can't breathe. And I'm not sure, but I think they put him on oxygen when that happens. So every time he handles hay, he has to put on a mask unless he's absolutely certain the hay doesn't have mold in it. And I used to know a librarian who every time she was around the books in the library, she had to wear a mask. Otherwise, she would get pneumonitis. My brother is a pigeon breeder, but he doesn't have pigeon breeder's lungs, and I asked him about it, and he doesn't know any other pigeon breeder that has pigeon breeder's lungs. But if you've ever been around pigeons, whenever they take off all at once in the pigeon coop, it really makes a really dusty mess. And so I understand why pigeon breeders get pigeon breeder's lungs. Any question about hypersensitivity, immune complex hypersensitivity type 3? Okay? All right. The last hypersensitivity is type 4 hypersensitivity, and that is cell-mediated hypersensitivity, meaning that this one is not mediated by the B cells. Type 4 is the only one that's mediated by T cells, and there are no antibodies involved in type 4 cell-mediated hypersensitivity. Because it's mediated by T cells, it takes longer for the body to activate the T cells, and then the T cells to go out and find the tissue that is, I don't want to say infected, the tissue that is has the antigen, and then attack the the tissue that has the antigen. So this one takes more time. It takes the longest time. And generally, I didn't talk about the time, but when we come up here and we talk about type 1, this one takes the shortest time. You can have a type 1 allergic response in just a few minutes, whereas the type 4 cell-mediated hypersensitivity, this one takes many hours, even a few days, 24 to 72 hours before you have the inflammation causing type 4 hypersensitivity. Any questions about that? So in the case of the type 4 hypersensitivity, the antigen usually comes from outside the body and crosses the skin or the mucosa. And a good example of type 4 hypersensitivity is the hypersensitivity that happens when people are exposed to poison ivy or poison oak. An antigen from outside the body comes and literally the antigen binds to our cells. And then the immune system responds to that antigen and causes inflammation and pus, which is the allergic reaction of poison oak. I actually respond that way to poison oak. And the antigen actually does no damage to our cells. It's just an antigen that you get from a plant, and then it gets on our cells, and then our own immune response responds with this allergic response, which is a type 4, and goes in there and starts killing the cells and causing inflammation for the region which is exposing the antigen from poison oak. And then there's a lot of dead tissues and accumulation of pus, and that's the example of poison oak. Any questions about that? Okay. As I stated, in all of the cases of hypersensitivity, it would be better if the immune system did not react. Like, so what if you're exposed to pollen? The pollen isn't going to harm you, and then you have this allergic response. And like in a Rh incompatibility, it'd be better if that never happened, if the mother never attacked the baby's blood. I don't know. Like I said, it's a case where you don't want that happening. And all the other cases, like a mismatched blood transfusion, that mismatched blood isn't going to harm you, but the immune system reacts to it and then will destroy that mixed mass blood. And then the hypersensitivity, like I said, my farmer, he would be fine if he handled moldy hay. The moldy hay isn't really going to harm him. The only reason why he gets harmed is because his immune system responds to it. So my point is, in all the cases of hypersensitivity, it would be better if the immune system never reacted to it. Any questions about any of that?
How long does type 3 take before signs show?
A couple of hours, meaning after my friend who is a farmer, I'm losing where that is. After he's exposed to it, it takes a couple of hours. And I don't have the time listed for that one. But it's a couple of hours. All of the B cell ones, except for the first, take a couple of hours, meaning the body has to respond to it and then produce antibodies. And the first time the patient is exposed to it, it doesn't take a couple of hours. It takes about a week. And then the antibodies are made. And so usually the first time the patient is exposed to it, the mold is already gone from the lung, and so the patient doesn't react severely to it. But the second times they have memory cells and they make the antibodies, and so it just takes a couple of hours. All right, so we mentioned that the immune system can cause disease, and we talked about 4 types of hypersensitivities. The immune system can also cause disease in other ways, and that is in the hypersensitivities. Generally, our body is responding to an antigen that came from outside the body. Even in the case of Rh incompatibility, the antigen came from the blood of the fetus. Okay? But the immune system can make antibodies and T cells to almost any antigens, including antigens or molecules of the patient. Now, normally, in early childhood, the body removes a B cell or a T cell that is making or responding to an antigen that is of the host. And we actually have a term for it. It's not terribly scientific, but it's the term for it. And they say the body prunes those cells. And so normally, in most healthy individuals, during early childhood, when they had a B cell or a T cell that was made and then responded to an antigen of their own body, that cell was pruned, removed. If that cell is not removed, then it results in an autoimmune disease. And the patient will grow up, and usually in young adulthood, the patient will have an autoimmune disease, where the patient reacts to a molecule that their own body makes. Any question about any of that? Okay, autoimmune diseases are of 2 types. They can be single tissue diseases, such as autoimmune hemolytic anemia. I actually knew a patient when I was in college, so I guess that was many years ago now, who had this, and she made antibodies to her own red blood cells. Back then, there was no medication for treating it, which really tells you how old I am, because I can't believe they didn't know how to treat that even back then. But every time it happened, she just got worse and worse, and eventually she became anemic because her own antibodies were destroying her own red blood cells. Okay? Nowadays, there are ways to treat this, and I'll talk about it at the end. Another one is the immunologic attack on the islets of Langerhans cells. And these patients make antibodies that attack the cells that make insulin. And so, not surprisingly, these patients become diabetes, and they become type 1 diabetes. Any question about that? How this was first discovered was they noticed that some cancer patients who were diabetics, when they were given chemotherapy, their diabetes disappeared. And then they did research and discovered that the chemotherapy weakened the patient's immune system, and then they lost their diabetes because their body was no longer attacking the islets of Langerhans cells. Any questions about that? And that was discovered as early as the 1960s, that some cancer patients who were diabetics, when they took chemotherapy, they lost their diabetes. And that's why it surprises me that it should have been obvious to doctors how you can treat some of these autoimmune diseases. Okay? And then people who have multiple sclerosis, their immune system, both the antibodies as well as the cytotoxic T cells, destroy the myelin sheath on their neurons. And that's why some people get multiple sclerosis. It's from their own immune system attacking their own neurons. Any question about any of that? Now, those are the single tissue diseases where the immune system is only attacking one tissue or one organ. There are also systemic autoimmune diseases where the patient their immune system is attacking many different tissues, many different cells of the patient. And these diseases are usually given names like lupus, where the patient makes antibodies and cytotoxic T cells against many cells of their body. And I have no idea why they make so many antibodies against so many different cells and so many different of their own antigens. I don't know why so many, but they just do. And something, because lupus, every patient is a little bit different because depending on what they're reacting to. One of the characteristics of a lupus patient is they'll have a butterfly marking on their face. This is sort of what you're seeing here. And it's from the antibodies attacking the skin of the face. Don't ask me why it's attacking the skin of the face, but it is. Another thing that's seen in most lupus patients is they make antibodies against their own DNA. Now, normally, antibodies never see a patient's DNA because the DNA is inside the nucleus, which is inside the cells. And the antibodies would only normally see the surface of the cells. But because these patients are destroying their own cells, the DNA gets released. And then they make antibodies against their own DNA. And then the DNA, if it's in the blood, and then it complexes with antibodies, DNA is a very big or long molecule, and then you have antibodies bound to that DNA, it makes a very big immune complex, which lodges in the kidneys and does damage to the kidneys of lupus patients. Okay? Any questions about lupus? I once had a student who was a lupus patient, and she got a flare-up in her disease while she was in the class and had to drop out of the class. And I never heard whatever happened to her, if she ever got better and that. I'll talk about it. There is something you can do to treat all of these immunological diseases, and I'll talk about that at the end here. Another systemic disease is some rheumatoid arthritis patients make antibodies which attack their own collagen, and that causes inflammation in the joints. And each time it happens, each time there's inflammation in the joints, there will be more and more damage to the joint. Eventually, the joint will no longer be able to bend, and so it'll be a totally stiff finger, assuming that it hits all of the joints, okay, because we've got actually in each finger, one in the knuckle, whatever that bone is called, and then that one can bend a little bit, this one here. But the point is that eventually the joint will freeze. Okay? All right. Now, I want to briefly mention that there is something you can do to treat the patients who are attacking their own antigens, meaning the patient is attacking their own molecules. and that is you can give them immunosuppressive drugs. And that weakens the immune system, and therefore the patient is less likely to attack their own antigens. Now the problem with this is once you begin it, you have to continue it for the life of the patient. And this patient will be at increased risk of getting an infection because they don't have a fully functioning immune system. In many of the patients, you can just weaken the immune system a little bit or part way. You don't have to totally remove the patient's immune system. You just weaken it a little bit, and then their own immune system doesn't attack their own molecules. Okay? And another case is if you just weaken the attack on the patient can sometimes live with that. In severe cases, you'd have to totally destroy the patient's immune system, and that's not good. The patient would be the same as an AIDS patient. Whatever infection they get, they would have no defense against it, and every time they had an infection, they'd have to come in to the doctors and get an antibiotic shot if it's an infection caused by a bacteria. But if it's an infection caused by a virus, we have very few antiviral drugs, and none of them are very effective. Any question about that? All right. Let me talk about my last topic here, and that is I have talked about hypersensitivities and immune complex disease or autoimmune diseases as separate entities. They are not separate entities, and they are not mutually exclusive. Sometimes they can overlap. I've talked about them as separate entities just because I think it's easier to discuss that way and much easier to understand when you're trying to figure things out. Some authors do not talk about them as exclusive entities because in reality they are not. You can have a hypersensitivity which is responding to your own antigen, in which case it will be both an hypersensitivity and an autoimmune disease. Okay? I've only talked about them as being separate because I think it's easier to discuss it that way. And I'm trying to make it simple for you to understand. Any questions about that? Is everyone good? All right, I don't hear any comments, so I'm going to assume everybody's good. Let me see if I've got any pictures to anyone. Nope. All right, so our last topic is that a patient can get an immune system drug, meaning an immuno response that is a disease, but not because the immune system is causing the disease, but because the immune system is defective. And then that causes an immunodeficiency disease, meaning all of the body's lines of defenses, you can inherit a defect in that defense. Any question about any of those? Now, very rarely do we have a patient who is defective in their skin or in their mucosal membrane. And I would assume the reason why that happened was before the advent of modern medicine. If a patient was born defective in their skin, they would have gotten an infection, and that would have killed off those individuals. And so those individuals didn't breed, and so those genes were selected against a long time ago. And so most of the inherited defects are caused in children who are born, who are deficient in making either an antibody or a cytotoxic T cell. Okay, any question about any of that? Now, depending on how severe the disease is, in the old days, that would be a death sentence, that the child might be able to live for a while and could survive maybe an infection or two, or maybe even three, but eventually the infection would overwhelm what functions of their defenses, and then they would die. And even today, some of these immunodeficiencies, the children die, and I'll talk about which ones. The most common immunodeficiency is children who are deficient in producing IgA. So the children are born and they have a gene that is deficient in making the IgA antibody. And these children have multiple respiratory and gastrointestinal infections. Any question about that? Surprisingly, some of these children did survive even before the advent of antibiotics. Other children are born and they're deficient in making IgG or IgM. And can anyone tell me why these children are deficient in making both antibodies, IgG or IgM? Can anyone think of a reason? Why would they be deficient in making both of those antibodies if they're only deficient in one gene? All right, nobody's answering, so I'll go ahead and answer. I'm not going to go ahead and ask people. Remember I told you that first the body makes IgM and it's secreted by the B cell, but that only happens for a few days. After a few days, that B cell stops making IgM, and then it starts making IgG, and then the B cell secretes the IgG. And so apparently, that gene is responsible for making both of these antibodies. Okay? These children, when they are born, they're susceptible to coming down with bacterial infections. In the days before antibiotics, this was a life killer. Sooner or later, the child, maybe they'd survive to young adulthood, but sooner or later they'd get a bacterial infection and then they would die from the bacterial infection. These children nowadays can survive because we have antibiotics. Okay? Then there's severe B cell deficiency. For some reason, it's mostly in boys, so apparently this gene is on the X chromosome, and boys only have one X chromosome, and so they're more likely to express this gene. And when they're born, they're unable to make any antibody. Not IgA, not IgG or IgM, and not IgD. And that's probably what's happening. If you don't make IgD, then the B cells can't respond at all. Anyways, these boys are usually okay with a viral infection or a eukaryotic infection. And the reason is that the cellular arm of the immune system, the cytotoxic T cells, can still function, and they can fight off a viral infection or eukaryotic infection. But they are no good at fighting bacterial infections. And until the advent of antibiotics, these children never grew up to adulthood. Okay? So usually they died before reaching adulthood from a bacterial infection. Like I said, nowadays, these children can survive, and you just have to give them antibiotics every time they have a bacterial infection. Any question about that? Here are 3 pictures of 3 patients who have severe B-cell deficiency. What's unusual is that these 2 were fairly old before it was discovered that they were severe B-cell deficient. And what happened was this little boy here kept getting sick time after time, and the doctor got suspicious and decided to test him for severe B-cell anemia or severe B-cell deficiency, and he turned out to be positive. And then the doctor thought about it and said, you know, his brother would have the 50% chance of having that disease, and he had 1 bout of pneumonia that was life-threatening. So the doctor decided to test his brother, and sure enough, even though he'd been relatively healthy, he only came down with pneumonia 1 time, he also was deficient in all of his B cells. Any question about that? All right. The next deficiency is the T-cell deficiency. These children lack a thymus, and the thymus is where the T cells mature. These children are susceptible to viral infections, and they'll just get one viral infection after another. They are surprisingly okay with dealing with bacteria infections. And what happens is their humoral arm of the immune system, the B cell arm making antibodies, works fine. And so they're quite good at fighting off bacteria infections. But they're lousy at fighting off viral infections. And these children, even today, seldom reach adulthood. Usually they die before adulthood, and if they do reach adulthood, they die early in adulthood. Okay? Meaning, even today, we don't have good enough drugs to help with viral infections in these children. Any question about any of that? All right? And then there's one worse immune disease, and that's severe combined immunodeficiency disease, also called the bubble boy disease. Children who are born with this disease cannot make any functional B or T cells. And there's the most famous case of this, David the Bubble Boy. These people, when they're born, they usually die in infancy because they have no immune system. David, the Bubble Boy, survived, gosh, what was it? At least into elderly childhood, something like 10, 11, or 12. And that's because he was in a bubble for his entire life. All right, any question about that? Well, that's the congenital immunodeficiency diseases and the hypersensitivities. If there's no question on any of that, we will begin talking about parasites. Our next lesson. Let's see, what do I want here? You know, maybe I should start with the other one because I do want to cover this pre-lesson here. So let's talk about what the learning goals are for the parasites. you need to know some of the medically important parasites. You need to know their names and how they're classified. You need to be able to describe the epidemiology of some of the parasites. And generally, I'll be talking about those when you need to know some of the epidemiology. Like when we talk about malaria, most people know that disease is spread by a biting mosquito, so that's its mode of transmission. Anyways, that's one of the epidemiology things we'll discuss. And anything I don't discuss, you won't need to know about. You also need to be able to describe some of the characteristics of the parasites, including the symptoms that the patient has. And if I don't mention any symptoms, then you obviously don't need to know any of the symptoms for that disease. Any question about any of that? All right. So we're going to review some of the medically important parasites. Many of them have complex life cycles where the parasite may live to finish out its life cycle in 2 or more host species. Most of the worms, that's not true for the pinworm, but for many of the parasitic worms, it will live in 2 host species. And if the parasite lives in 2 or more species, then we say that it has 2 different types of host. The definitive host is the species where the parasite reaches final maturation and can reproduce, and reproduces often sexually. So that's the definitive host, where the parasite reaches final maturation and reproduces usually sexually. The other host that the parasite is living in, or the other species, is a species where the parasite is in an immature or juvenile life cycle. The parasite can grow and develop in that other intermediate host, and it can reproduce, but if it reproduces, it usually reproduces asexually. Any question about that? In the lab, we're going to be looking at human parasitic worms, and they are in the kingdom animals, and the parasitic protozoa of the kingdom protists. The protists are often, or the protozoa, because that's the area of protists we're going to talk about, the parasites that infect humans. The protozoa are often divided on how the parasites move. And that is not a modern genetic classification system. It is a classification system that is made for clinical identification, and the clinicians just look at the parasite under the microscope, and then they notice how the parasite moves, and that's how we're going to divide up the parasites. Now, the good news is that the clinical classification on how the parasites move is also similar to the genetic modern classification system. So on the left here, we're going to separate the parasitic protozoa into 4 phyla, and on the left, the sarcodines, the zoomastigates, the Psyllophora, and the apicomplexa. That's the modern genetic classification system. But on the right, the amoeboids, the flagellates, the ciliates, and the sporozoans, this is the clinical classification system based on how the parasitic protozoan moves. And as you can see, they are essentially the same. Okay? Any question about any of that? So the amoeboids meaning the phyla Sarcodines. These parasitic protozoa move by pseudopods. And pseudopods, you'll remember, are an extension of the plasma membrane and the cytoplasm. And the cell just moves. Where did that go? There it is. Oh, that's not going to work. All right, never mind. Let me see if I can get that to work. Actually, it won't work. I've been in another browser either. That's a little video showing you of a cell move. I'll try and copy that link, but I don't think it's going to work in another browser. Meaning that the little movie, I don't have a program that can run movies. So, sorry, you're going to have to watch that on your own if you got it. What is that? There's a free download on the internet that will allow you to watch movies, and I'm sorry I haven't downloaded that. Anyways, what you'd see is an amoeboid moving by putting out the cytoplasm, and then on the opposite end, how do I do this? On the opposite end, the cytoplasm moves up, and so the cell moves by putting out pseudopods, and I've got a little movie on that. The flagellates are the zoomastigates, and these parasitic protozoa move by flagella. Remember, the flagella are what bacteria use if the bacteria move. The ciliates, or the ciliophora, these are the parasitic that are covered with little cilia, and they use these cilia to move. And if I can show you the cilia, we'll see if I can do that. There's no bacteria that have cilia. The apicomplexa, or the sporozoans, they either move like undulating, like a eel moves, or they're non-motile, like malaria is non-motile. Any question about any of that? All right, let's go to this one. Let's see if I've covered everything. We'll talk about that later. The trophozoite is the protozoan parasite when it is moving, living in its normal life cycle, and reproducing. A cyst is a parasitic protozoan when the environment becomes unfavorable to the trophozoite, and then the cyst forms, and that allows the parasite to survive in harsh environmental conditions. If a parasite has a cyst life cycle, for humans, the cyst life cycle is usually the life cycle that infects humans. And that's true for all of the parasites which are consumed, and the cyst can survive the stomach digestive juices and acids, whereas the trophozoite, if it is consumed, it would die in the stomach. Any question about that? And we already talked about the two kingdoms. We'll be looking at the kingdom animals, and that includes the parasitic worms or helminths, and the kingdom protus, which includes the parasitic protozoans. All right, any question about any of that? So the first parasitic protozoan I want to talk about, and the only important amoeboid protozoan, the only one I'm going to talk about, is Entamoeba histolytica. Let's look at the figure here. And here you're seeing a trophozoite of Entamoeba histolytica. And maybe I can blow that up a little bit. You see the nucleus has a bullseye appearance, meaning an eye. These are not nuclei because this is a trophozoite. The trophozoite only has one nucleus. These are red blood cells that the amoeba has engulfed. Any question about that? Entamoeba histolytica can cause amoebic dysentery. And amoebic dysentery is frequent and painful diarrhea, often associated with blood and mucus in the diarrhea. The reason why there's blood is the Entamoeba histolytica can burrow into the mucosal lining and damage the intestinal lining, causing ulcers in the large intestine. And then they can bleed, causing blood in the stools. It is possible to find Entamoeba histolytica, the trophozoite, in a stool, especially if the stool is soft, okay, or if it's diarrhea. But the cysts are more likely in a human stool because it's fairly dry and the cyst survives that dry environment. Any question about that? And then the cyst will survive in the environment. Let's say somebody is hiking in the desert and then they go to the bathroom in the desert, and let's hope that they bury it. And then the desert sand will dry it out. The trophozoites would quickly die, but the cysts will continue, and they will just survive for a long time in the desert. And let's say somebody comes and, I don't know, they're hiking in the desert. Let's say it's a year later and they drop, I don't know, something on the ground like an apple, and they pick it up. And that apple picks up a cyst from the ground. And then that apple is ingested. The cyst will survive the stomach digestive juices and then will contaminate the patient. And when the cyst reaches the intestine, the trophozoite will form, meaning the cyst life cycle will switch to the trophozoite, and then the parasite will start becoming metabolically active, eating food in the gut of the patient and reproducing. Any question about any of that? Now, you can get cysts from contaminated food, meaning food that has fecal matter on it, or hands that have fecal matter on it, and then other contaminants, like if you went to a third world country and they had the sewer system leaking into the water supply, and the cyst could be in the fecal matter, contaminating all of these things, and then you could consume the cysts. How to stop the transmission of Entamoeba histolytica is mainly use good personal hygiene. If you wash your hands before eating, you're not going to get the cysts. If you eat cooked food or food that is washed very well, it'd be very hard to remove all the cysts from lettuce or something like that. But you could wash an apple very well and you would not get any cysts on it. Okay? And then have effective water treatment plant, meaning you shouldn't have your well water contaminated with the sewer. And in the United States, that doesn't happen, but in third world countries, it does happen. And then the last thing for preventing the spread of Entamoeba histolytica, don't use human manure as fertilizer. In Southeast Asia, they use human manure as fertilizer, and as you can imagine, that region of the world is much more prone to Entamoeba histolytica than other regions of the world. Any question about any of that? All right. There are 3 clinical results you can get when a patient is infected with Entamoeba histolytica. and which result you'll get will depend on the health of the host before they're infected and the virulence of the strain that infects the patient. Meaning, if you're a healthy adult and then you become infected, you're more likely to be on the top result. And if you're unhealthy, you're more likely to be on the bottom result. And of course, there are different virulence for different strains, and some of them will be more likely the top result, and others will be the bottom result. Any question about any of that? Okay, the first clinical result is where the patient is asymptomatic. The trophozoites are breeding and reproducing in the patient, but they're largely staying in the lumen of the intestine, eating things in the lumen. The patient may, get less food, but they just eat more and then they're fine. Meaning the trophozoite is not damaging the intestine. And these patients are asymptomatic. The trouble is they can excrete many cysts, and so the asymptomatic carrier can spread the entamoeba to other patients, and they may not be asymptomatic. A patient can excrete millions of cysts per day. Any question about that? All right. The next clinical result is invasive amoebic dysentery, and that's characterized by the patient having diarrhea, colitis, that's inflammation of the colon, bloody stools, and pain. What's happening is the trophozoites are invading the intestine and doing damage in it. They're burrowing into it, causing it to bleed, causing the patient pain. It can result in death, especially if the patient doesn't have adequate health care. Any question about any of that? All right. The third clinical result of invasion by entamoeba is extraintestinal amoebiasis, where the trophozoites do more than just damage the intestine. They burrow into it and then invade the bloodstream. And then they can travel elsewhere in the body. Now, the place that is most often damaged, where the trophozoites are most likely to go, is the liver. If you've had anatomy and physiology, you would learn that in the intestines we have a vein that takes the food that is digested and then takes that food with the hepatic portal vein to the liver. And so the trophozoites can get into that vein and then go to the liver and then invade the liver. So you can see liver abscesses, and that's an area in the liver with necrosis and inflammation. Rarely the trophozoites can go to other tissues and cause abscesses elsewhere, but that's very rarely. Usually it's the liver that's hit. And usually in these cases, the liver is hit twice. Not only is the trophozoite causing direct damage to the liver, but the trophozoite in the intestine is damaging the intestines, and there will be a bacterial infection, debris and toxin that will be flowing out of the intestines. And where does it go? It goes down the hepatic portal vein to the liver. And then the liver has to deal with that. All of the bacteria, the debris, and the toxins, and the noxious substances flowing from the intestine. Any question about that? All right. So that's Entamoeba histolytica. Let's go on and talk about the flagellates. To keep an eye on the time here, so let me move that down a little. There are a couple of flagellates, the phyla Mastigophora, that I want to talk about. The first is Giardia Lamblia. It's a flagellate that causes diarrhea. The patient can have inflamed bowels. They can feel bloated, nausea, and sometimes they can have a fever. What's unique about these patients is their stools have a rotten egg smell, rotten egg, from the production of hydrogen sulfide, meaning the parasite, the Giardia Lamblia, the trophozoite, can create hydrogen sulfide. And here we're looking at Giardia Lamblia, the trophozoite. This stain isn't showing you the flagella, but it would be a whip-like structure right here attached to the trophozoite. And it's showing you kind of like a face where the trophozoite has two nuclei and sort of something in between the two nuclei that look like a nose. Once again, with this parasite, it's the cyst, which is the infective agent and can survive the stomach acid. So if you get infected, you're likely to get infected from the Giardia Lamblia cyst. Any questions about Giardia Lamblia? That's all I'm going to talk about them. I suppose you could say that sometimes this parasite can be found at low numbers in the water supply of cities, because animals, poop in the water supply, and then that parasite can be at low numbers in the water supply. Usually for a healthy adult, we do not get infected, but for people who are AIDS patients, this is a concern. And if it's found in their water, they should filter their water or treat it to remove that parasite. Any question about any of that? I sort of shouldn't have said that. I spoke too much about that. The next flagellate I want to talk about is Trypanosome cruzi. And this is a parasite, a flagellate that causes Chagas disease. This disease is found in Latin America, and has recently actually migrated and is found in Texas, meaning it's come across the Rio Grande River, I think that's what it's called. And so you can find it in mammals, and especially opossums and armadillos, harboring this parasite. So probably what happened is some mammals from Mexico swam across the river and they brought it into Texas. The bug which spreads Chagas disease to humans is a true bug, meaning it's in the bug family of insects, why it's called a true bug, Triatoma. And the name for it is the kissing bug because of its habit of getting a blood meal from a human, usually biting them on the lips when the patient is usually asleep. Any question about that? And so that's how we get the parasite Trypanosoma cruzi, is from the kissing bug biting the patient, usually on the lips, and the triatoma is going for a blood meal. So let's go look at its abbreviated life cycle. The parasite reaches final maturation in the triatoma, also called the kissing bug. And what it does is, you don't need to know the names of the different stages of the parasite. So it has one name here, one name there. That's the same name. That's the same name. So whatever that was, two different names. You don't need to know the names. We're just going to talk about it as the parasite reaches final maturation and then sexually reproduces in the triatoma. And that happens in the gut of the triatoma. And then the gut releases its eggs for the parasite in the feces of the bug. And the bug, when it's finding a patient, and you can sort of see it there, see how it's biting the lip of this patient? When it's biting the lip of that patient, the bug gets its blood meal. And then the bug, when it's getting its blood meal, it defecates near the site of the bite. Initially, the parasite is not in the patient. But what happens is the bug then goes wherever the bug goes, and then the patient wakes up, and what do they have on their bite? They have an itchy, sore spot. And what do? They take their finger and they rub it on the itchy bite. And what they do is they take the feces and the eggs in the feces, which gets on the finger, and then the finger deposits into the bite. And that's how the patient becomes infected, meaning the patient is actually infecting themselves, that the bug just defecates near the bite. Okay? And then the patient is infected by the eggs of the parasite, which are in the feces of the triatoma. Remember that the triatoma just has the parasite. The bug is not the triatoma is not the parasite. And then the bug in the human, oops, I don't have that, so this should be here. The parasite gets into circulation and infects cells of the patient, largely macrophages, heart cells, and liver cells. And the parasite grows in these cells, reproduces, and then when the parasite is mature, it destroys the host cell, releasing more of the parasites into the blood, which will infect more heart cells, more macrophages, and more liver cells. Any question about that? What continues the life cycle is that while the parasite is circulating in the blood of this patient, another triatoma can bite this patient to get its blood meal, and then that's how the triatoma gets infected, by biting a patient that is infected. And then the triatoma takes in the parasite in the gut, and that's where the parasite reaches final maturation and then goes through sexual reproduction in the gut of the triatoma. And that's the life cycle of Trypanosome cruzi. Any question about that? All right, I'm just checking to make sure I talked about everything. The parasite is an immature parasite when it is in the human. The definitive host is the kissing bug. Any questions about that? So disease progression usually goes through these steps. First, there's swelling at the bite site. Okay, let's look at that in a little bit better. And that child doesn't look too happy that he's being photographed here, but in reality he was very lucky. Somebody noticed that the child was bitten by the kissing bug, and sure enough he was infected. So what happened is someplace near the bite mark, the triatoma bug deposited feces here, and then the child moved the parasite into the wound, and then that wound was infected. Any question about any of that? And then the parasite gets into the blood and travels in the blood and can infect lymph node cells, heart cells, other cells like liver cells. The patient can have swollen lymph nodes, feel a little sick, get a fever, and that's when their immune system is first reacting to the parasite. Unfortunately, the parasite hides out in the patient's own cells, reproducing, and so the immune system is not clearing it and has a hard time clearing it when it has infected one of your cells. And then the patient gets better, and they may be in the asymptomatic stage, and this stage may last for years, but every once in a while their cells will burst, releasing more parasites into the blood, and then those parasites will infect other cells and then grow in those cells, eventually bursting those cells. And eventually the illness ends with congestive heart failure. Why is that the end for the patient? Why does the patient have congestive heart failure?
Too many cells are bursting.
Yeah, their heart cells are getting infected, and as more and more of them get infected, the patient will eventually have congestive heart failure. The disease can be treated if it's caught early. And the reason why it can be treated only if it's caught early is if the damage has already been done to the heart, you're going to have that damage done. The heart doesn't have cells that can grow and replace the cells that have been burst. So the treatment has to be done early, preferably early in the asymptomatic stage or earlier. Like I said, this patient got it in the first stage, the picture here, and he was very lucky. Okay? Any question about any of that?
If the person doesn't move the feces into the bite, will they still get infected?
No, they will not be infected unless the parasite is moved into the wound. And for some reason, the bug itself, which is not the parasite, does not defecate in the wound. Okay? So normally it's the patient themselves which infect themselves, and that is they move the parasite from the feces into the wound. So if ever you're in Latin America and you get bitten by the kissing bug, what you should do is don't scratch it, get alcohol and clean that area first, and that will kill the parasite. Okay? All right, it's now 2:15. I think it's time for us to end this. Is that right? Yep. All right, so if there's no further questions, I'll see you at 2:30.